So imagine you are experiencing this really debilitating chronic physical pain.
Right, the kind of pain that dictates how you sit or how you move and just fundamentally disrupts your intimate life.
Exactly. But here's the really crazy catch. When a doctor actually looks at the source of this pain, they see absolutely nothing.
Yeah, to the naked eye, the tissue just looks perfectly healthy.
The pain is entirely invisible. And because it looks so normal, I mean, the standard medical approach for you is going to be super conservative. Creams, physical therapy, maybe pain meds, or even psychological counseling.
Which is standard, but for many patients, those treatments just fail completely.
They do. Yet, paradoxically, there is this highly specific, localized structural surgery that boasts up to a 90% success rate for this invisible pain.
It's fascinating. Surgeons are literally cutting away what looks like flawless tissue to cure a neurological firestorm.
And that is exactly our mission for today's deep dive. We are unpacking the exact surgical principles behind this procedure. It's called a modified posterior vestibulectomy.
Right, and it's used to treat localized provoked vulvodynia, or LPV.
We're going to synthesize surgical guidelines and clinical trials just to understand exactly how surgeons physically rewire this hypersensitive pain network. Because it's so wild to me that you can use structural surgery to solve a neurological pain issue.
It completely defies, our standard medical expectations. We are so conditioned to think that severe pain requires visible damage.
Like a broken bone or a deep cut.
Exactly, or severe inflammation. But with LPV, you are looking at what appears to be a completely normal anatomical landscape because the core issue is actually microscopic.
Right, I saw in the sources that they use these specific nerve staining techniques to see what's actually going on.
Yeah, and those studies show that patients with LPV have up to 10 times the normal density of C. efferent nociceptors, and that's in the epithelium of their vestibular mucosa.
10 times the normal amount. That is a massive amount of pain nerve fibers packed into one small area.
It really is. And those C. efferent nociceptors are the nerve endings responsible for sensing things like burning or raw sensation.
So a physician looking at the vulvar vestibule, which is this specific ring-shaped tissue we were talking about, they just see normal tissue or maybe a slight redness.
But functionally, it's a completely different story. To help you visualize this area, the vulvar vestibule is a very specific ring of tissue.
Okay, let's break down the anatomy for the listener.
Sure. So on the inside, it is bounded by the hymen. And on the outside, it is bounded by something called Hart's line.
And Hart's line is basically the biological border, right? Where the smooth mucosa meets the outer skin-like tissue of the labia minora.
Spot on. It extends from the very bottom, which we call the posterior fourchette, up toward the top near the clitoris. And that smooth tissue inside the ring is where this massive hyperproliferation of pain nerves occurs.
It honestly makes me think of a home security system.
Oh, how so?
Well, normally you would put a couple of standard motion sensors at your front door, right? But in a patient with LPV, it's like the biological contractor accidentally wired thousands of hypersensitive motion sensors into that single entryway.
That is a great analogy.
They are packed so densely that, like a leaf blowing across the porch or even just a change in humidity, sets off a deafening 5-alarm siren inside the house.
Yes, exactly. The physical hardware of the door looks totally fine, but the electrical wiring is completely overloaded.
Wow.
And because of that extreme density, these women experience allodynia, meaning they feel sharp pain from a stimulus that shouldn't provoke any pain at all.
Like just a very light touch.
Right. And they also experience hyperpathia, which is this wildly exaggerated response to a mildly painful stimulus. Their nervous system is just screaming danger when there is no actual threat.
Which sets up a huge surgical challenge. I mean, if the sensory wiring in this specific ring of tissue is totally overloaded, how do surgeons ensure they are cutting the correct wires without damaging the rest of the house?
Well, the surgical guidelines really stress that this modified posterior vestibulectomy is traditionally a last resort.
Right, after the physical therapy and multidisciplinary pain management fail.
Yes. But before a surgeon even considers taking a scalpel to this tissue, they have to rule out another condition entirely, which is vaginismus.
Vaginismus, okay.
Yeah.
That's a muscle issue, isn't it?
Exactly. It's an involuntary muscle spasm of the pelvic floor muscles. LPV, on the other hand, is a mucosal nerve issue.
Ah, I see. So if a patient's pain is primarily driven by deep muscle spasms, surgically removing the superficial mucosal layer isn't going to do anything.
It will do absolutely nothing. You cannot cut away a muscle spasm with a vestibulectomy.
That makes total sense.
A patient might have both conditions, sure, but if the muscle component isn't addressed, the surgery will appear to have failed. So ruling that out through a careful pelvic exam is the absolute first step.
Okay, so assuming the patient is confirmed to have LPV, they eventually end up in the operating room. And the sources describe this preoperative mapping process called the cotton swab test.
Yes, it's a crucial step.
But wait, the patient is on the operating table and they are awake for this part, right?
They have to be awake, yes.
That's wild to me. The surgeon uses a cotton swab to methodically press against the vestibule, like hour by hour on a clock face, to map out the pain. They are actively provoking this agonizing tissue before giving anesthesia.
I know, it sounds harsh, but since the tissue looks completely normal to the naked eye, the surgeon must rely entirely on the patient's real-time physical reactions.
Just to figure out where the hyperdense nerve clusters begin and end.
Exactly. Without that live feedback, the surgeon would be flying blind. By doing the cotton swab test while the patient is awake, they use the subjective experience to draw objective borders.
So when the patient reports that severe cutting pain, what does the surgeon do?
They take a surgical marking pen and literally draw parallel lines directly onto the affected tissue, marking exactly where the excision needs to start and stop.
They're essentially drawing a blueprint of the hyperalgesic zone.
Right, usually extending these lines up to Hart's line and down to the perineum. And once that precise blueprint is drawn onto the patient, then they are placed under general anesthesia.
Okay, so the patient is finally asleep. But the vulva is an incredibly vascular area. Cutting into that tissue must result in an immediate rush of blood, right?
It definitely would.
Which would instantly obscure those ink marks and just ruin the surgeon's visibility of the borders they just spent all that time mapping.
You're exactly right. To prevent that, before any cutting begins, the surgeon infiltrates the marked area with a local anesthetic mixed with a vasoconstrictor.
Usually epinephrine, right?
Yes, specifically epinephrine. The anesthetic manages the severe pain the patient would otherwise experience upon waking up. But the epinephrine serves a structural purpose.
It shrinks the blood vessels.
Exactly. It shrinks the blood vessels in that localized area. This dramatically reduces bleeding during the procedure, keeping the visual field perfectly clear.
So they don't lose track of their margins. But pumping fluid into the area must also change the physical shape of the tissue, too.
It does. It creates what we call a hydrodissection effect.
Hydrodissections, okay.
Injecting the fluid physically plumps up the tissue, kind of like a water balloon. It lifts the superficial mucosal layer, where all those extra pain nerves are away from the deeper underlying muscular structures.
Oh, wow. So that physical separation makes it much easier for the surgeon to just shave off the top layer without digging too deep.
Precisely.
So let's actually focus on the mechanics of that cut. Because the name of the procedure modified posterior vestibulectomy, it tells us exactly what they are doing.
Right. The modified part is key. Historically, surgeons performed a complete vestibulectomy, removing the entire ring, including the tissue right up around the urethra.
But the modified version limits the excision to just the posterior or bottom portion. So we picture the vestibule as a clock face. They're only cutting out a horseshoe shape from the 2 o'clock position down to the 10 o'clock position.
Exactly, leaving the top portion near the urethra completely intact.
Why the change?
Well, removing tissue around the urethra carries a much higher risk of altering the urethral angle, which can cause urinary complications. And many women with LPV only experience the severe pain in that posterior horseshoe area anyway.
That makes sense. By modifying the procedure, they minimize the risk to the urinary tract while still targeting the primary source of the pain.
Exactly. So the surgeon takes a scalpel or an electrocautery tool and excises the mucosa within that outlined blueprint. And the depth of this cut is highly specific.
Right. They only go 2 to 5 millimeters deep.
Just 2 to 5 millimeters.
That is incredibly thin. It's like the equivalent of peeling the skin off a grape.
It really is. And they stay that shallow because those hyperdense C-afferent nociceptors are located strictly within the superficial epithelial layers.
So if a surgeon cuts deeper than 5 millimeters, they aren't even removing any additional pain fibers.
No, they are just digging into healthy muscle and fascia, which would unnecessarily increase blood loss and the risk of nerve injury.
Okay, so the inner margin of this shallow cut removes the hymenal ring entirely, and the outer margin stops exactly at Hart's line.
Right. The goal is to remove the biological real estate where the nerves have proliferated, but absolutely nothing more.
But wait, I saw there was a massive debate among surgeons in the literature regarding this specific step, specifically surrounding the Bartholin's glands.
Oh, yes. It's a huge surgical controversy.
So these are the glands responsible for natural lubrication, right?
Right.
And they sit just beneath this posterior tissue with their ducts opening directly into the vestibule.
That's right. And some surgeons argue you absolutely must remove these glands during the excision.
Why, if they're healthy?
Well, their logic is that if you leave the glands behind after cutting away the tissue above them, the ducts can get blocked by post-operative scar tissue.
Oh, and that blockage turns a healthy gland into a chronic, painful Bartholin cyst.
Exactly. Nobody wants to cure a patient's nerve pain only to give them a chronic structural cyst.
Yeah, that would be terrible. But surgeons on the other side of the debate strongly disagree, right?
They do. They point out that the overall risk of developing those cysts is actually quite low. And to remove the Bartholin's glands, a surgeon has to dig much deeper than those initial 2 to 5 millimeters.
And we just established that going deeper pulls the surgeon out of the safe zone and into the danger zone for major anatomical structures.
Exactly. Digging for those glands drastically increases operative time and blood loss. But most critically, it puts the surgeon in very close proximity to branches of the pudendal nerve.
Oh, wow. And the pudendal nerve runs right through that deeper pelvic area.
Yes. So if a surgeon accidentally severs or damages a branch of that nerve while trying to remove a Bartholin's gland, they can cause permanent, catastrophic pelvic pain and numbness.
A pain that is far worse than the original LPV.
Much worse.
It's a profound risk calculation happening right at the operating table. The surgeon is weighing the relatively small chance of a localized cyst against this rare but devastating chance of permanent, life-altering nerve damage.
It really highlights the precision required.
So they've navigated that risk, and they've successfully removed this very thin, horseshoe-shaped crescent of nerve-dense tissue. But this leaves a raw, open, physical defect.
A physical gap, yes.
You cannot simply stitch the two edges of the gap together, right? I mean, if a surgeon just pulled the skin from Hart's line tightly across the gap and stitched it to the vaginal wall, the opening would be stretched completely taut.
It would be terrible. The patient would suffer immense structural discomfort and tearing the moment they moved or attempted intimacy.
You would essentially be replacing a neurological pain with a severe mechanical stricture.
Exactly. Which is why the reconstruction phase is arguably the most mechanically ingenious part of the procedure. It relies on something called a vaginal advancement flap.
A flap. So to cover the raw defect without creating any tension, the surgeon basically has to borrow tissue from somewhere else.
They do.
I was thinking about this, and imagine you have a fitted bed sheet, and it is popped off the corner of your mattress.
Okay, I'm with you.
You can't just grab the very edge of the sheet and staple it to the corner of the bed. The material is already pulled tight, and it will rip the moment you put any weight on it.
Right, it would just tear.
Instead, you have to reach further down the side of the bed, pull the slack up from a flexible area, and use that extra borrowed material to cover the exposed corner smoothly.
It's a perfect analogy, or like pulling a window blind down to cover a drafty sill. You are borrowing slack from an area that has it to cover an area that needs it.
So how do they actually do that in the body?
The surgeon grasps the posterior vaginal wall, which is highly elastic and naturally has plenty of slack, and gently separates it from the underlying tissue.
Okay.
This underlying layer is called the rectovaginal fascia. The surgeon undermines or frees up about 2 to 3 centimeters of this vaginal mucosa.
So they're essentially creating a flexible flap of healthy tissue.
Exactly. A flap that can be pulled down and out of the vagina to smoothly cover the raw horseshoe shape left by the excision.
But pulling the flap down is one thing. Anchoring it in place has to require a very specific technique. The sources mention tension-free suturing, right? Often using dissolvable sutures.
Yes, tension-free is the key word here. And they don't just use a simple running stitch like you would to close a paper cut. They use deep mattress stitches.
What's the difference?
A mattress stitch doesn't just grab the edges of the skin. The needle goes through the vaginal mucosa flap, but then the surgeon drives the needle deep into the underlying rectovaginal fascia before coming back up through the mucosa.
Ah, so by anchoring the flap to the deep connective tissue rather than just the superficial skin edges, the physical tension is distributed across a much wider structural base.
Exactly. It ensures the closure is completely tension-free at the surface layer, which is where the healing needs to happen. If there is tension at the surface, the flap will literally tear itself open or dehisce during the recovery process.
And anchoring it deep also forces the flap to sit completely flush against the tissue bed underneath it, right? If the surgeon just stitched the top edges, it could leave a pocket of empty space underneath the flap.
Which is incredibly dangerous. In surgery, leaving dead space is just a recipe for complications.
Because blood will just pool in there.
Invariably. It pools in that empty space and forms a hematoma. And a large hematoma can put outward pressure on the flap, cut off its blood supply, and destroy the graft entirely.
Wow, so the deep mattress stitch eliminates that dead space.
It does. Furthermore, the direction of the stitches is critical. The surgeon places the stitches sequentially from anterior to posterior.
So front to back.
Yes.
Because if they stitched it from side to side, they would risk cinching the vaginal opening together, like pulling the strings on a drawstring bag.
Exactly. Stitching front to back guarantees that the introitus, the vaginal opening, retains its normal anatomical diameter. The entire goal of this reconstructive flap is to ensure that normal anatomy and sexual function are fully restored without adding new mechanical constraints.
It is essentially architectural remodeling with living tissue.
That's a great way to put it.
They map the sensory firestorm, surgically shave off the exact hyperdense layer, and pull down a tension-free flap to cover the exposed foundation.
And when we look at the outcomes of this architectural remodeling, the data is striking, especially compared to those conservative treatments we mentioned earlier.
Right. Across various retrospective studies and clinical trials, 60 to 90% of patients report significant pain relief.
And some cohort studies show over a 90% satisfaction rate after a couple of years of follow-up.
That is a staggering success rate for a chronic pain condition.
It's a completely life-altering outcome for the majority of these patients. But there is a fascinating nuance in the medical literature regarding the histology.
Oh, right. The microscopic examination of the tissue after it has been surgically removed.
Yes. You would naturally assume that if a pathologist looks at the excised tissue under a microscope and counts the density of those C-afferent nerve fibers or inflammatory mast cells, they could predict the surgical outcome.
Yeah, the logical assumption is that a patient with a massively high nerve count would have a guaranteed successful outcome because the surgeon removed a clearly defined pathology.
Exactly. But the studies show that the histology does not predict the surgical outcome at all.
That is so wild to me.
Right. The concentration of nerve fibers found in the lab after the fact has no statistical correlation with whether the patient actually feels better post-operation.
So the objective lab data is entirely blind to the patient's actual recovery.
It really challenges how we view medical proof. In so many areas of medicine, we rely heavily on objective biomarkers, like a tumor size or a white blood cell count.
But in chronic pain conditions like LPV, the diagnostic gold standard remains the patient's subjective experience.
Exactly. Doing a preoperative biopsy to count nerve fibers just to see if a patient is a good candidate for surgery is completely pointless.
Because the decision to operate is driven entirely by the awake cotton swab test and the patient's real-time experience of pain. Now, we also have to balance that 90% success rate with the physical realities and risks of surgery, because one study noted a nearly 19% complication rate.
Which isn't insignificant. Complications can include flap dehiscence, where those stitches give way before the tissue fully heals.
Right, or a decrease in natural lubrication, which is sometimes temporary, but, can persist. And there's also the reality of the modified aspect of the procedure itself.
Yes, because the modified vestibulectomy intentionally preserves the anterior vestibule to protect the urethra and urinary function, the nerves in that remaining top portion of the tissue are left intact.
So there is a documented risk that hypersensitivity could develop in that remaining anterior tissue months or years down the line.
Correct. The surgery solves the posterior pain, but it doesn't guarantee the anterior nerves won't eventually misbehave.
Even with those risks, this procedure is triggering a pretty compelling paradigm shift in gynecological literature.
It really is.
The established guidelines still suggest conservative treatments. Creams, antidepressants, extensive physical therapy as the mandatory first step.
But several sources point out that many of those conservative treatments perform no better than a placebo in randomized controlled trials.
Right. If conservative therapies are frequently functioning as a placebo and require months or years of expensive, psychologically draining effort, while a localized day surgery boasts up to a 90% success rate, some researchers are actually starting to challenge the traditional medical dogma.
They are asking why this highly effective surgery is strictly kept in the last resort category.
Right.
With appropriate, thorough, informed consent about the potential complications, leading researchers are arguing that vestibulectomy should be evaluated as a first-line treatment for carefully selected patients with LPV.
Because why subject a patient to a prolonged trial and error process with systemic medications when a structural repair can fix the localized wiring problem directly?
It's a very valid question.
So to kind of synthesize the surgical principles we've covered today for you listening, the modified posterior vestibulectomy succeeds by doing three highly specific things.
Let's recap them.
First, mapping the exact pain zones while the patient is awake to create an objective blueprint from subjective pain.
Yes.
Second, employing hydrodissection and shallowly excising only 2 to 5 millimeters of the posterior vestibule, removing the hyperdense nerve networks without hitting deeper structures or major nerves.
Spot on.
And third, utilizing a tension-free vaginal advancement flap anchored with deep mattress stitches to restore normal anatomy without creating painful strictures.
Perfect summary. And there's actually a broader, deeply profound concept hidden in the embryology of this tissue that I think is really worth pondering.
Oh yeah, tell me about that.
The medical texts note a brief but crucial fact. The vulvar vestibule originates from a completely distinct embryological structure called the urogenital sinus.
Okay, what does that mean?
It is endodermal tissue. This means that during fetal development, the tissue that forms the vestibule folds and migrates from a completely different biological origin than the tissue that forms the rest of the vagina right next to it.
Wow, it's like two different contractors built adjoining rooms in a house. The vagina and the vestibule look connected, but the vestibule's cellular wiring and hormonal sensitivities were programmed by a completely different company with a different set of biological blueprints.
That is a fantastic way to look at it. Because it is endodermal tissue from the urogenital sinus, it reacts differently to hormones, trauma, and inflammation than the surrounding structures.
Which raises an incredible question for the future of pain management.
It does. If this specific, highly localized patch of tissue can be so uniquely prone to nerve fiber hyperproliferation simply because of its embryological origin, what does that mean for the rest of the human body?
Right. Could mapping the unique embryological origins of tissue across the body unlock surgical cures for other chronic, unexplained pain syndromes?
Exactly. We might eventually treat other invisible pains not by constantly searching for visible damage or prescribing endless systemic painkillers, but by using a highly targeted approach based on the ancient cellular blueprints of where that specific patch of tissue came from.
It forces us to entirely reconsider how we categorize pain. Sometimes a localized pain isn't a systemic failure, but just a highly localized biological glitch rooted in how that specific tissue was formed in the womb.
It's a whole new frontier.
It brings us right back to our opening thought. Sometimes the invisible pain isn't in a patient's head, and it isn't a mystery meant to be managed indefinitely. Sometimes it is just a miswired alarm system waiting for a surgeon to come in, map the unseen borders, and physically hit reset.